everybody. Thank you very much for inviting me to this distinct, beautiful meeting. I enjoy the virtual meeting very much. Today, my topic is treatment of acquired superior oblique palsy. Superior oblique palsy is one of the most common causes of vertical deviation in children and adults. And there are two types, congenital and acquired. Today, I'm going to focus on acquired superior oblique palsy. The causes for acquired superior oblique palsy are trauma, vascular diseases, idiopathic, tumor, and iatrogenic. And within these causes, trauma cases are most difficult in diagnosis and treatment. How to diagnose acquired superior oblique palsy? Park's three-step test is the most popular way to diagnose three-step test. But recently, magnetic resonance imaging are more powerful tool to confirm the superior oblique shape and function. Interestingly, sensitivity of three-step test is only 70% of MRI positive superior oblique palsy patients fulfill. That means rest of 30% of patients who is diagnosed as a three-step test with MRI are not positive in three-step test. Moreover, Birshovsky-Hatcher test for diagnosing bilateral superior oblique palsy is very poor. Park's three-step test is sensitive only 24% of diagnosed by objective bilateral fundus extortion. On the contrary, subjective net bilateral extortion over 10 degrees on Lancaster red-green test straight ahead, its sensitivity is quite high. So the bilateral acquired superior oblique palsy is very difficult to diagnose clinically because they have small vertical deviation in primary position, V pattern, and large torsional deviation exceeding usually 15 degrees. So we cannot miss bilateral superior oblique palsy after head trauma. We need to check the torsion. So how to evaluate the cyclotorsion? This is an instrument developed by Dr. Hayashi in Japan. It's a kind of double Maddox rod test, but this instrument has very fine scales with 1 degree interval, and patient can rotate the dial and fix the angle of two lines to parallel. So it is quite subjective and very precise. This is a synoptophore. We use this for measuring the 9 gauge of position of cyclotorsion. Also, fundus photos is useful to evaluate the torsion. When the fovea locates below the line of the optic nerve head, it means excyclotorsion. And when the fovea locates higher than the center of the optic nerve, it means encyclotorsion. How to treat this bilateral or unilateral superior oblique palsy, acquired superior oblique palsy? Prisms, it do not correct the cyclotorsion, but when the amount of horizontal, vertical, and torsional deviation is small, still we can use the prisms. Correct vertical deviation and horizontal deviation with prisms. Patient may fuse with small cyclotorsion. So we wait 6 months and winning the power to wait a spontaneous recovery. But after 6 months, if the patient still has the torsional diplopia, we go for surgery. This is a very popular procedure to correct cyclotorsion without changing the vertical deviation. It's named Harada-Ito procedure, published in 1964. This procedure is anteriorized anterior part of the superior oblique tendon for correcting cyclotorsion. Interestingly, in original article, they published both inferior oblique and superior oblique surgeries. Recess the anterior part of inferior oblique tendon for correcting cyclotorsion is also published, but only the superior oblique tendon anteriorization became popular worldwide. How are the other procedures to correct cyclotorsion? Inferior oblique weakening procedure is strong and stable technique. Myectomy, recession, anterior transposition, and even nasal and anterior transposition is developed, and it is a very strong power to correct cyclotorsion. Superior oblique strengthening can be full tendon tucking and also Harada-Ito. I would like to emphasize the effectiveness of contralateral inferior rectus muscle weakening procedure. It can be recessed with or without nasal transposition. Inferior rectus muscle recession with nasal transposition is developed by von Norden in 1996. He reported the effectiveness about 5.8 degrees. And recently, Dr. Okamoto performed on 90 cases, and the effectiveness is quite similar. We measured the 9 gauge of cyclotorsion in 6 patients. In the primary position, average cyclotorsion is 12.8 degrees. But in down gaze, the cyclotorsion increased to up to 20 degrees. We performed bilateral inferior rectus muscle recession with a half muscle wide shift. Post-operatively, the cyclotorsion in primary position decreased to 2.7 and in down gaze 4.7. That means that this technique had effectiveness in 10 degrees in primary position and 15 degrees in down gaze. Look at this patient. This patient has a large extorsion for 30 years without diagnosed after closed head trauma. There are very little eye movement disorder, and this patient was not complained double vision for a long time, but not understood. This is his health chart. He has a significant V pattern, and fundus photo showed severe cyclotorsion. And this is the cinemode MRI in corona, and both superior oblique muscle were small and did not functioning with up gaze and down gaze. This is a synoptophore with 9 gaze. His cyclotorsion in the primary position was 32 degrees, and it increased to 38 degrees. We decided to perform bilateral inferior oblique myectomy and bilateral inferior rectus muscle recession with nasal transposition. This is the pre- and post-operative head chart. His V pattern improved quite a lot after 12 months post-operatively. And fundus photo increased, became very normal, and also the 9 gauge of cyclotorsion decreased in the primary position to 2 degrees and in down gaze only 7. This is a single binocular visual field, 1 week post-op and 12 months post-op. Here is the comparison between inferior rectus muscle recession with nasal transposition versus Harada-Ito. Compared to Harada-Ito procedure, inferior rectus muscle recession is easy to perform and can be adjustable and easy to reoperate and correct both vertical deviation and torsion with 1 session. The problem is late overcorrection may be possible, but on Harada-Ito, a late undercorrection is a problem. There is no randomized control trial to date, so we can choose either way. So the take-home messages, check torsion after head trauma. Try Prism first. Inferior rectus muscle recession with nasal transposition is a very powerful tool and easy to perform. Can be combined with inferior oblique muscle weakening procedure or Harada-Ito procedure. Thank you very much for your attention.